Fragile process and dissociative process are concepts that enable the person-centered therapist to work with the person in relationship, the person in process. This is somewhat, I suppose, at odds with traditional forms of looking at mental health, like diagnosis, like the medical model, which can be more about deciding on what kind of person someone is. So how fragile process presents, for example, could be conceptualized as a personality disorder. Dissociative process may be conceptualized as someone having schizophrenia. These labels can be really helpful and they can be really validating to a person. The risk though, and I suppose this is where it runs counter to the person-centered approach and most forms of therapy in general, is that a person could see themselves as identifying with these labels. I am schizophrenic, I have a personality disorder, and them seeing that as the beginning and end of the conversation. I was listening to a podcast I think recently where somebody highlighted within this logic it can be quite circular. So if someone asks, why are you hearing voices? They can say, oh, it's because I'm schizophrenic, I have schizophrenia. And then someone else can say, how do you know you've got schizophrenia? And they can say, oh, it's because I'm hearing voices. And it's circular and it doesn't actually relate to what the possible meaning of these experiences actually are. Another way of putting this could be that mental health diagnoses describe what's happening, but they don't explain. I mean, it's the old adage again that I've talked about already, the map not being the terrain. Diagnoses are a very useful map, potentially, in helping people navigate their experience and understand it. It can be helpful just to know that, oh, my experience or the kinds of things that I'm experiencing is recognised enough in different people for there to be a diagnosis that fits me. That can be really quite nice. The issue, though, is any individual person is more complex than any of the concepts that we've created for them. And I think if you deny that or avoid that, in my opinion, you do violence to the person as a human being if you see them purely through the lens of these boxes that we've created to fit people in. I think it's also worth bearing in mind, though, that the labels that we've created to understand things are somewhat socially constructed. They're based largely on our own biases and our own culture and our own society and how we choose to conceptualize things. A good way of making this clear is to consider how other cultures in history or other parts of the world conceptualize mental health. For example, there's a diagnosis of drapetomania, which is often given to black slaves during the transatlantic slave trade. A lot of the black slaves often came down with drapetomania, and you can probably talk about this as though it's a real mental illness, until it's explained that the main symptom of drapetomania is the black slave wanting to run away from their slave master. At which point I hope it becomes clear that drapetomania is simply a tool to place the problem on the slave rather than the person having to reflect on the injustice embedded within that society. There's numerous examples of this. Apparently, for example, in the USSR, not believing in the USSR was regarded as a mental disorder at one point. I can't remember where I heard about that, but if true, it makes sense. It's a very good way of silencing people and not having to reflect on certain questions being asked if you can dismiss someone as having a mental disorder. Judith Harmon talks about a couple of other examples in her book Trauma and Recovery. So she talks about hysteria and how apparently Freud made a connection between hysteria, the label that was often given mostly to women in the late 19th and early 20th century. He made a strong link between hysteria and being sexually abused as a child. He didn't back this up though. He talked about it, said he would write more about it, and there's theories, there's rumours about why he didn't do that. It's believed, certainly in this book, she believes that it's due to the ramifications of what that would mean. That would mean that a very, very high number of little girls are being abused in the society that Freud was a part of. And he existed in that society, and you could say that he decided not to confront with that because it may have had an impact on his career, or you could speculate on other reasons. Either way, it's another pretty good example of how the label hysteria can hide the truth. Another example, yet again, as discussed in this book, is masochistic personality disorder, which was often used to place the problem within women who were being abused and didn't leave their partners. Perhaps they'd internalised the abuse, they felt so helpless and powerless that they didn't feel able to leave. And as you can see again, rather than acknowledging the injustice of them being abused, the problem is placed in the person who is being through the horrible things or is continuing to go through the horrible things. I think these are all examples of ways in which labels can be used, not necessarily, but they can be used as ways in which a society can avoid having to reflect on some quite uncomfortable questions. For example, if you acknowledge that trauma is a large part to do with the development of mental health difficulties, then the next question becomes, how do you create a society where trauma is reduced as much as possible? And then you have to go into all these hopeful questions about how unequal the world is and injustice and social progress. And I think there's a lot of people that would prefer society as a whole not to ask those kinds of questions. Personally though, when it comes to labelling and diagnosis, I am less inclined to be looking at it in terms of what the person is or who the person is. I look at people in terms of what's happened to them, and I ask them what's happened to them rather than what is wrong with them. Most likely there's nothing fundamentally wrong with them, in my opinion. Even people who dissociate, even people who have fragile process, even people who have suicidal thoughts, on a fundamental level, my belief is that there's nothing absolutely wrong with them. What has happened is that they've gone through some stuff, and the stuff they've gone through has had an impact on them, and their way of coping with the stuff that they've gone through is continuing to have an impact on them. That's how I see people. The problem is out in the world. The problem is with the rapist. The problem is with the people who do things or create societal conditions through neglect or a lack of funding that results in people getting traumatized. The person isn't the problem. The person is a result of the problem. This isn't to say that people aren't responsible for their own behaviour on an ongoing basis. I don't want to infantilize people and look at people in a way that suggests that because you've gone through X, Y, Z, therefore, you're not responsible for the harm you're doing right now. James Gilligan, in the video on actualizing tendency, the video that I did, I mentioned James Gilligan, and he talked about violent criminals and how many of them have been through some quite incredible trauma in their life. That doesn't excuse the things that they've done, because they're still responsible for themselves. Where do we go if people aren't responsible for themselves? You've got to be responsible for yourself. I think the danger with diagnosis, though, if it's presented and dealt with in a certain way, is that it takes a person's agency and therefore their responsibility out of the equation. If their illness is due to a chemical imbalance, or if it's just something that's randomly come out of the sky and has hit them and there's absolutely nothing you can do about it, then it's hard to see where responsibility can possibly come into that. It's also hard to see where society as a whole can begin to take responsibility for that, if that is how it works. On the subject of depression being caused by a chemical imbalance, here's a relevant quote. The chemical imbalance theory of depression was first described in 1965 by Joseph Schildkraut, a scientist at the National Institute of Mental Health, in what became the most frequently cited paper in the American Journal of Psychiatry. He presented the theory as a hypothesis, and his words, at best a reductionistic oversimplification of a very complex biological state. And this might lead you to question, well, what are diagnoses actually based on then? Diagnoses for mental health disorders. And here is a quote that's used in Mary Boyle and Lucy Johnston's book, The Power Threat Meaning Framework. They both quote Dr. David Kupfer, who was the chairperson of the task force which produced the DSM-5, which is the document that outlines all the mental health disorders and problems that are recognised by the medical community. He says, in the future, we hope to be able to identify disorders using biological and genetic markers that provide precise diagnosis that can be delivered with complete reliability and validity. Yet this promise, which we have anticipated since the 1970s, remains disappointingly distant. We've been telling patients for several decades that we are waiting for biomarkers. We're still waiting. Mary Boyle and Lucy Johnston in this book talk quite eloquently about the difference between mental health diagnoses as opposed to the diagnosis of a physical health condition. So for example, if you have diabetes, you may have some symptoms. You may want to go to the toilet quite a lot. You may feel quite thirsty. There'll be a few other ones. And there's the symptoms, there's the biological test, which I suppose is a blood test to see your insulin levels. And then there's the diagnosis after you've gone through the biological test. As is acknowledged by David Kupfer here, when it comes to mental health diagnosis, there is no second stage because we do not have biological markers. All we have are the symptoms, and we have the DSM-5, which outlines the clusters of symptoms which we have decided are associated with different labels that we can give people. Understanding this about mental health diagnosis might beg the question of how the different categories have come into existence in the first place, and Mary Boyle and Lucy Johnston helpfully explore that as well. What happened was that mental disorders and their official diagnostic criteria were and still are voted into existence by committees on the basis of whatever the committees decided were symptoms. Worth bearing in mind that historically these have often been male committees, often been white committees, and you could argue that the diagnostic criteria may well represent biases as a result of that lack of diversity. And they quote a couple of people that were actually involved in the process. Professor Donald Klein, for example, a leader in developing diagnostic criteria, put it, "We were forced to rely on clinical consensus, which admittedly is a very poor way to do things. We thrashed it out. Basically, we had a 3-hour argument. If people were still divided, a matter would eventually be decided by a vote." And they also quote Renee Garfinkel, a psychologist who took part in the DSM meetings, who puts it more plainly. "What I saw on those committees wasn't scientific. It more resembled a group of friends trying to decide where they want to go for dinner. One person says, 'I feel like Chinese food,' and the other person says, 'No, I'm really more in the mood for Indian food.' And finally, after some discussion and collaborative give and take, they all decide to have Italian." And of course, if someone finds their diagnosis really helpful and really validating, then I think that's entirely valid. I think that's great that they found something that they find helpful. From my point of view, though, I'm going to work with them as a person. I'm familiar with a lot of the diagnostic labels, but I see that as a diagnostic label. It's a tool, it's a way of looking at things, it's a map. The person in front of me is the terrain, and the only way I'm going to understand the person in front of me is by listening to them and not letting any category get in the way of my ability to listen to them openly.